Hello, my name is Juan Loy. I'm a P3 student here at the Ben and Métis Fish College of Pharmacy. Today I will be doing a journal club, but first let me introduce my audience.
Hi, Jocelyn Hernandez.
Tucon Lamb.
Nathan Shire.
Cherokee Caton.
Justin Merrill.
Okay, so today my journal club is going to be over a study labeled Combination Therapy with Once Weekly Glucagon-like Peptide 1 Receptor Agonist and Dipeptidyl Peptidase 4 Inhibitors in Type 2 Diabetes. This is the case series. So the article was published by Lathia Bucate and colleagues. A little bit of a background. So the National Treatment Guidelines recommend glucagon-like peptide receptor agonists, or GLP-1 RAs, as add-on therapy to oral agents. However, GLP-1 RAs in combination with dipeptidyl peptidase 4 inhibitors are not recommended due to a lack of evidence. In previous studies, there have been one specifically mentioned, a randomized non-inferiority study comparing the addition of exenatide twice daily to sitagliptin, or switching from sitagliptin to exenatide twice daily in patients with type 2 diabetes experiencing inadequate glycemic control on metformin and sitagliptin. So the hypothesis on the case series that I'm doing today is based on their mechanisms. So GLP-1 RA inhibitors and DPP-4 inhibitor therapy, they both have the potential to have a synergistic effect by increasing or decreasing the GLP-1 levels above what is observed by monotherapy with either class. So the objective in this case is aiming to describe the safety of once-weekly GLP-1s administered concomitantly with DPP-4 inhibitors, and to confirm that the combination does not provide synergistic effects. Funding sources, there was none provided. The study site was at Crossover Healthcare Ministry. This is a free health clinic in Richmond, Virginia. The enrollment date started in about the summer of 2014, specifically July, to the fall of 2016 in September. Their follow-up was 12 to 24 weeks, or roughly 3 to 6 months. On the endpoints, there was a primary endpoint which measured the change in HbA1c and the weight from baseline to the next available A1c and weight within 3 to 6 month period. On the secondary one, it included patient-reported adverse events documented in the EMR, which is an electronic medical record. The number of patients requiring insulin initiation in Group A, and also change in insulin dose for Group B. Okay, so in my methods, the study design was a retrospective chart review of the EMR at a free health clinic. It was conducted between the summer of July 2014 to the fall of 2016. As far as enrollment, there was a total of 43 patients that were identified as receiving the combination therapy. Of the 43 patients, there was 18 that actually met the inclusion criteria for the case series, and you can see that in Figure 1 if you switch over to that. Out of those 18, there was 8 patients on oral treatment for type 2 diabetes that were assigned to the first group, Group A. Then there was 10 patients on insulin therapy that were assigned to Group B. As far as the inclusion criteria went, what was mentioned in the article, they said it was patients 18 years and older with type 2 diabetes that were included if they received concomitant DPP-4 inhibitor therapy and once-weekly GLP-1 RA inhibitor therapy, with at least one glycated hemoglobin A1c measurement within the 3 to 6 month period of starting the combination. As far as the exclusion criteria, they didn't specifically mention, but it looked like it was patients less than 18 years old with or without diabetes and patients that are not over the age of 18. As far as interventions went, in Group A, patients received metformin, DPP-4 inhibitor, plus a sulfonylurea prior to the index date. On the second group, it was patients that were prescribed insulin therapy plus other oral agents prior to that index date. Okay, and as far as the statistical analysis went, it looks like at 3 months, the median IQR, HbA1c, and weight change was negative 0.8% and negative 0.4 kilograms respectively. So none of the patients actually reached an A1C level below 7%, and only 3 patients, which is 17%, reached an A1C less than 8%. Patient-reported adverse effects included GI disturbances, hypoglycemic symptoms, and injection site reactions. On baseline characteristics, there was a number of them. So if you refer to Table 1, there is a handful of them, and I can read off a few of them. Some of them range from age, weight, gender, race, and many more on the table. So on our primary outcome, it was primarily the change in A1C levels and weight over the time period. So the patients in Group A experienced a moderate A1C and weight reduction at 3 months after starting combination therapy, and the median interquartile range, IQR, A1C and weight changes were negative 0.9%, so a good improvement, and negative 0.8 kilograms respectively. You can also see that on Table 2 if you're interested in that. Okay, so for my secondary outcome, this was typically mostly dealing with the adverse events. So the adverse effects were actually combined in both of the groups because they had similar effects. Those included the GI disturbances, which came out to 28%, hypoglycemic symptoms, 17%, and the injection site reactions, which were 0.6%. The adverse events, as mentioned earlier, the GI, hypoglycemic, and injection site reactions, but there was one single injection site reaction that was actually just with the exenatide extended release form, so that was the only outlier on that one. As far as dropouts went, it looks like there were some that were excluded from the analysis. It was a total of 25 of them. The EMR error recording combination therapy had 14 of them drop out because of the error, so it has to exclude bias. There was a few of them that were lost to follow-up. They just did not come back to these studies, so they took that out to avoid bias. There were certain ones that had daily GLP-1 receptor agonist. With those, you have to take those out because that's a weekly GLP-1s. There were 6 of those that were dropped out, and then there was only one of them that had 6-month HbA1c data that was actually missing, so we wanted to have those all in there, but we excluded all those as to avoid bias. So on the author's discussions and conclusions, they briefly mentioned a little more, but essentially it came down to given the approximate average wholesale price for DPP-4 inhibitor and GLP-1 RA classes, which are USD 434 and USD 887 respectively. Outcomes from this case series are unlikely to be cost effective. The author advises for clinicians to continue or to discontinue DPP-4 inhibitors in patients not meeting glycemic goals before initiating a GLP-1 RA inhibitor. Okay, and this last section, it's going to be the study strengths, limitations, and as far as the strengths went, there was no patients that actually elected to discontinue the GLP-1 RA or the DPP-4 inhibitor therapy due to intolerable adverse effects. Another strength was that this allowed for testing of the hypothesis whether they would have a synergistic effect and work together in decreasing the A1C and also increasing weight loss. Another one was the study did not require any funding. Also, there was actually no conflict of interest in this study. Okay, so on study limitations, the study was based off a small sample size. So it was just not one small clinic. They only used the one clinic's EMR records. The secondary outcomes included patient-reported adverse events documented in EMR, so that could also lead to a bias in reporting. This was also a retrospective case design, which can be a limit in itself. So group A and B, the age and sex was varied. There was not consistency in the population selection. On insulin, this was added into the second group. There's a common adverse effect that is weight gain, which is part of the main study. So that definitely could have skewed the data, maybe caused a little bit of bias. On applicability and impact on the clinical practice. So this actually just reinforces the current guidelines that really just prefer the other more cost-effective medications and therapies. This actually also allows the guidelines to be further implemented in scenarios where people have limited incomes, especially in older populations, people that have Social Security checks and just kind of a fixed income. And this last part is my conclusion and my recommendation. Overall, I do agree with the conclusion that the author came to regarding the concurrent therapy of GLP-1s and also the DPP-4 inhibitors. So the medications in question are typically already more expensive than the conventional diabetic regimens. A lot of times for type 2 diabetics, they start out with metformin, and it's a little more cost effective, and a lot of times they have the same success. So therefore, after reviewing this study, the additional costs the patient would have to pay actually was little to no benefit in overall health, and is just more expensive overall for the patient. And there's not as many health benefits to this medication. So with that being said, I can open up the floor to any questions if anybody has any.
Yes.
Okay, perfect.
Okay, so how was the study done without any funding?
That's actually a great question. So I had the same question when I was going through the article myself. So it actually turns out that this is a retrospective case design. So what they did, they just went to a clinic and they went to their electronic medical records. So they didn't actually do any actual studies or anything. They just went through different records in that clinic over the time period of the fall or the summer of 2014 to the 2-year period when it finished.
Okay.
So they weren't required to have any funding really.
Okay, sounds good. Thank you.
So what do current guidelines say about combination drugs?
So at the moment, what the guidelines actually refer back to, it says they actually recommend that just the GLP-1 agonist just be an add-on therapy to current oral agents. So there's not enough evidence right now for them to have the combination of GLP-1s and DPP-4s, just because kind of what the study went over, it's just not cost effective and there's not enough health benefits.
Thank you.
What would you have done to make this study better?
So the study was kind of a small sample size, kind of in a limited area. So if I would have been able to do it, I would have possibly changed a few different things, like sample size. I would have gone a little bigger, maybe distribute it over the country, and also I probably would have made it a prospective study, because a lot of times the retrospective study kind of has limitations in itself, and you can kind of progress and watch the results as they happen. So that's how I changed it. Yes.
Do you feel like there was any true conflict of interest in this study?
So on that one, it was kind of weird. I was looking through, and I guess a lot of times when they do studies with this kind of thing, there's other companies, like specific companies, that would fund the study to make one of their products or another company look better or worse. So, and this one I didn't see anything because it was just an independent group of researchers that were just doing it just to test the efficacy and safety of this. So I didn't see any actual conflict of interest in this one.
Okay, thank you.
So did they adjust for the weight gain for the insulin use, or?
I was actually going through the article on that one, and I didn't see any adjustments on there. I can definitely skim back through. I noticed that was later on going through the article. That's a big impact, or it could have a big impact since it's comparing the weight gain and A1C levels, so it can have a big impact. I didn't specifically see anything on there, but I can definitely look into it a little more and get back to you, and just let you know if I find out anything a little more. But is there any more questions?
Yeah.
All right.
Sure.
Perfect. All right, and that is my journal club.